This conference will now be recorded.
It's Tuesday, August 26th, 2025, or November 1st, 2022. Pick your choose your date. Welcome to the AnCan virtual support meeting for high-risk, recurrent, and advanced prostate cancer. Thank you all for joining. I'm moderator Ben Nathanson, and I'm joined by moderators John Antonucci and Rick Davis, founder of AnCan. You'll have medical issues discussed, but we're just a bunch of guys. Nothing you hear is to be taken as medical advice. Sponsoring for this meeting comes in part from the sponsoring companies, and we thank Bayer, Novartis, Johnson & Johnson, Myriad Genetics, Telix, Blue Earth Diagnostics, Foundation Medicine. So let's begin. I don't think we have any new people tonight. So Alan, you were bumped last week, so you get to go first tonight.
Okay, Ben. I just want to provide you guys with an update. I'm almost 3 months into my treatment with the Lupron and apalutamide, and my PSA went from 21.2 on June 6th to 0.6 on July 25th. That's the latest, most recent measurement I have. My testosterone was at 0.4. Actually, it's 7 using your system in the US on July 25th. So it seems to be working pretty good. My doctor, she said that we just need to meet every 3 months and have a PSA and testosterone monitored. So treatment seems to be working well. Of course, I have the hot flashes and I have a hard time sleeping. And I go to the gym to try to minimize muscle loss and weight gain. But overall, I mean, despite the circumstances, I'm pretty confident. So that's my update.
Yeah, off to a good start. Did she warn you about rashes with the apalutamide?
I did have some minor, really nothing to worry about. So that's not an issue so far. Maybe it's gonna get worse. I don't know, but no, nothing significant.
Have you made her aware?
Like in the in between in the groin areas. Yeah.
So what I was told is that you need to nip these things in the bud, that the rash can get worse
Okay.
if you don't act early. So, my suggestion would be to let your doctor know that that you have developed a rash on the apalutamide that you didn't have before.
Okay. I have a cream that I used, and it seemed to be doing the trick,
Hmm. That may be all she would do too.
like a zinc cream. Yeah. But otherwise, my head is still pretty clear, if it has ever been clear. And I didn't gain weight so far, but I
Hmm.
see that it's gonna happen most likely.
That is really hard to avoid.
Yeah. And of course, my masculine functions are completely gone. So that's not fun. Of course, it's numbed. It's everything below the below is numbed. So yeah,
Yeah, yeah.
yeah.
Sorry, I joined late. What drug were you taking? Are you taking?
I had a shot of Lupron, and I'm taking apalutamide.
The Lupon. Okay.
Yeah, I've got another injection coming up. Yeah,
Anyone
so
have?
but
I'm sorry.
I'm just the hot flashes are problematic, and I know that some of you guys are using this bracelet. Is it effective? It's very expensive here in Canada. I'm hesitant to purchase it, but if it works, I'm gonna because my work is I teach at the university, and I see having flashes in front of all of the students that I feel fearful a bit about this. I start teaching in 2 weeks. I'm just wondering if it's worth it, that bracelet or not. if it prevents or if it reduces or if it does anything at all.
Jeff Markey is not. Yes, Jeff. We're talking about Wave.
I must have missed it.
Okay, there we go. Okay.
Yeah, you want me to comment?
Sure.
The device works quite well if you are not having extreme hot flashes where the sweat drips down over your eyes. In that case, it helps a little. But the thing that helps the most is the night mode. And I found I used to have the sheet wet under me and get hot flashes and hot sweats at night, and it almost completely stopped that. I mean, I've just never had that problem again. So if you're having that, it's a real benefit.
Yeah, I definitely wake up in the middle of the night and I'm all wet, and then so I'm hot, and then I get cold because I'm sweating. So
yes, that really makes a big difference in the night.
okay.
The night mode is really good on it. They've got 2 buttons, one for day,
Yeah.
hot flashes, and one for night. And I've got all the steps written out to configure it properly. They may be able to help you do it.
Okay.
If you run into problems, you could ask, and I could email them to you.
Okay.
So,
I have a link to where to get the device on Amazon. So I will probably go ahead because I need to do something, at least if it works for the night. That's
right
gonna
now, it's
it's gonna be.
$100 off at Ember Labs and
Oh,
themselves, and they
okay.
have a 60-day money back guarantee.
Oh, okay.
So you may want to check there. I just saw a few days ago they had the $100 off.
Okay.
So you want embrlabs.org. You may know that already.
Yeah. I appreciate
Okay.
it. Thank
Very
you.
good.
John A., you wanted to comment?
Yeah, a couple of things. One is on the hot flashes. Um, quite a substantial percentage of the guys at AnCan that try it get benefit, but there are some who don't, and those people have their ember waves just sitting in the drawer doing nothing, and often they will give or sell it for a low price. So if us moderators could keep an eye out for someone with an extra one in their drawer for you, we could probably get it at a good price.
Yeah,
The
that's
other
good.
thing is that if the ember wave doesn't work, you might have to consider some type of hormonal treatment. Guys AnCan have benefited from estrogen and progesterone treatment, and just get back to us if conservative treatment doesn't work. We'd like to get you in good shape by the time school starts again.
Okay.
And
Thank you. Yeah.
then the last thing was that the sleep problem that you're having is something that we should, I think, highlight, because probably the majority of people in this room have had sleep disturbances from one reason or another, hot flashes, pain. I think in your case, your apalutamide is interfering with your sleep medications and
Yeah.
inducing their metabolism,
Correct.
and you need to try something else. I don't know if you've tried melatonin or not. It might be worth a try.
Yeah, it's too weak for the issue that I have. What my doctor said, she increased the dosage of one of the meds, and it kind of works, but my sleep is really not the way it used to be before, since I started the
Yeah,
treatment. So, and in the correspondence with you, Dr. John, you said that all medication of that sort, they tend to become ineffective using the apalutamide that I'm using, right? So, yeah,
I looked up a number of alternatives that I used to prescribe, and I couldn't find anything that didn't interact. It
yeah,
doesn't mean that switching to different ones might not be an idea, though, because you never know what's going to happen with a different medication. So, sort of, keep at this problem,
yeah,
and either through sedation or through changing drugs, or controlling hot flashes or whatever, so that you can enjoy a little bit of decent sleep.
yeah,
And Ben will probably call for other ideas because a lot of guys here have faced this.
Okay. Thank you.
Rick, what say you?
So a couple of things. Just the first thing is just practical. You say it's very expensive. How expensive is it in Canada? Because I
It's
know
not.
the price.
It's no. Oh, you mean the device is about $300 Canadian?
Yeah, that's what it costs here.
Okay.
So,
Okay.
our view is, yeah, I mean, $300 is a lot of money, but for what it delivers, it's well worth it. So
Yeah.
we can't get it for you any cheaper. Yes, it's expensive. Our experience, as John said, is it works for many guys. If it doesn't work, you can return it. If there's anybody that's on the call or who listens to the recording who has one that they're not using, they can contact us. We'll put them in contact with you, and maybe you can cut a deal. But $300 is what they are now. Jeff says that they're on sale, so maybe you can get them for $200. But I would say, if it were me, it's a good investment.
Okay.
The second thing, and you get your money back if it doesn't work. The second thing is, for me personally, the Lupron, and I was only on Lupron at that time. In fact, at that time, there wasn't even an ARSI approved. But it certainly messed up my sleep badly.
Okay.
And largely because I got a lot of hot flushes during the night. Half the time you don't even realize. You wake up in the morning, you feel like a Mack truck hit you,
Yeah.
and it's horrible.
Mhm.
And I went through it for 2.5 years, and I think that most guys who are on hormone therapy of some sort or another face this issue.
Okay.
It's not unusual, to a greater or to a lesser extent. So it is what it is.
Yeah.
I also believe it's one of the reasons why we suffer from brain fog, because we're not getting proper sleep.
Yeah.
And that messes us up. And when our sleep's interrupted 5 or 10 times a night, half of the time we don't even know it.
Mhm.
We're not even aware that that's what's happening. So this little gizmo that, as Jeff says, it works really well. If you put it on the night mode, may help you, may make a huge difference, but it may not. The last thing I wanted to say to you was that the hormone therapy totally disrupted and changed my sleep patterns. So ironically, whilst I had trouble sleeping, whilst I was on it, prior to that, I got by very well on 6 hours, and I didn't need more than 6 hours. 6 to 7 hours, I was great. After I came off the Lupron, and I don't know anybody else who's had this effect, but I sleep way longer. I sleep 8 to 10 hours pretty much every night.
Yeah.
And it's easy for me to sleep 10 hours. I couldn't sleep 10 hours if you paid me before.
Mhm.
But now I find it just totally changed my sleep patterns. So
Okay.
just
Good.
saying.
Thank you. Thank you, Rick.
How have
Thanks, Rick.
people responded to the Orgovyx? The other,
Yeah, we know what you mean, Orgovyx, but you gotta please raise your hand.
yeah, I'm
You
sorry.
wanna? No, the raise hand feature. Let's see where it says, at least on my screen toward the bottom of there, it says react. It shows a figure of a hand.
Right. Next to the recording, right next to where it says recording. If
Oh,
people can use it, it makes it much easier,
There you
way
go.
easier.
Thank you. Thank
The,
you. That really helps me keep track of everybody who
right.
wants to speak. And Jack, you wanted to speak. Speaking of,
I just wanted to mention, it's been mentioned before, but I turned the volume down on my hot flashes to some degree by using phytoestrogen, soy isoflavones. They're supplements. You can buy them Life Extension or a lot of supplement companies, and I feel it has diminished the hot flashes to some degree, certainly has not eliminated them. And, there are lots of fancy drugs out there that claim to eliminate them, but I would try this first and see if it makes a difference. Soy isoflavones, and you can get them. Life Extension is one of the companies that makes them, and there are other drug companies, supplement companies that make them.
Can
Check it
can you
out.
can you kindly type the the name of the
Soy,
medication? Yeah.
soybeans like,
Oh,
Put it
soy.
in the chat window, please, Jack, if you can. Well,
uh,
I'll put it in for you, Jack.
okay.
Okay, thank you.
Thank you, Rick.
Thanks, Jack. Jamaican.
Yeah, I've got to start this drug this week, this Orgovyx, and I'm very reluctantly having to start it. And I was questioning about whether the hot flashes, that seems to be the one issue that most people are concerned with. And I was wondering how others have experienced that with this Orgovyx, how you pronounce it.
I think you mean Orgovyx, Orgovyx.
Yeah, Orgovyx. Yeah, I don't know how to pronounce it. Yes,
A lot of
I'm.
these drugs are challenged to pronounce.
Yeah, I've got to start it this week. I haven't started it yet. Just got the prescription, so I'm a little concerned about the side effects.
So,
And
Jim, did you ask for time tonight?
no, I just logged on a
Oh,
minute ago. I was late getting in
Okay,
here.
so let's just add Jim to the list, Ben,
Okay,
and then we can talk to him about what he might expect. Can we do that?
Yeah, after the
good plan.
Right. We'll come back to you. And there's a really interesting comment from John McPhee, and we've gotten this comment before. Why don't we mention estrogen patches when we talk about the control of hot flashes? And we've had people ask us that before. And we have had guys who have supplemented their ADT with an estrogen patch. And I think it does work. Is Dr. Paul on tonight? I thought I saw him
He's
before. Yes, Dr. Paul. What is your thought about supplementing? Somebody's on ADT, whatever it is, but they're suffering from hot flashes, sleep issues. What would you say about just adding a patch, and how do they approach that? How do they get their HCPs to agree to that plan, and how much, et cetera, et cetera?
Well, good questions and tough answers in a way. The easy answer with regard to efficacy is it will reduce dramatically all the symptoms that have been discussed with regard to sleep, hot flashes, brain fog, and also something you haven't discussed because it's long-term, which is osteoporosis. Because the main problem with the side effects is the absence of estrogen. I know that sounds kind of counterintuitive to the male, but we all need a little bit of estrogen. And when we are given androgen deprivation, which reduces the T dramatically, we don't have any leftover to pathway to E. So it works. I mean, I've been on it for a long time. I've been on LHRH. I've been on the patch. I can vouch for personally dramatically different relief of the side effects of at the time, Eligard. Now, the hard part is how to get it, because estrogen has a bad name in the circles of medicine because of a long and outdated oral intake, not transdermal delivery. Transdermal delivery bypasses the worrisome cardiovascular and thromboembolic handles that have been associated with estrogen.
I understand in Canada, you cannot prescribe off-label. So, I mean, it's against the law, presumably. I don't live there and haven't tried, but that's what I've heard. Now, in the States, you have to find a physician who is understanding of the plight and willing to prescribe estradiol patches, which are a number of them available for women, but it's off-label for men. And it's 2 patches twice a week, even 1 patch twice a week would I think make a difference. You're using it not to be a androgen deprivation substitute, which is what I do. You're using it as an add-on to blunt the side effects. So a much lower dose is necessary, and usually 1 or 2 patches twice a week will do that. But you have to have I will close by saying my last hurrah on the earth, whether it's a year, 2 or 3, is to go full Monty on trying to bring estrogen into the standard of care consideration option list for men like us who have been on androgen deprivation therapy. It's going to be a hard push, but as Ben knows, there's a trial that will be published that shows equal efficacy and a heck of a lot of quality of life benefits. And the osteoporosis is one of them that's really morbid for the future with regard to fractures, etc. So thank you. Too much said probably, but you gave me the microphone, and there you are.
Yeah, thank you, Paul. I'm going to close the window on this topic. We've been talking a long time about it. We have others who want to speak, so I apologize to people whose hands are raised. Mark Valens, you're next.
Well, this last week has been one of the most challenging in my life. A week ago today, my nephew flew out from Colorado to pick up my his grandfather's 1967 Camaro convertible, which I had for 33 years. It was sad to see it go, but my spine is so full of mets, I can't even drive anymore and certainly can't work on it. So it's staying in the family. That's good. But then the next day, and my younger brother Dan picked him up my nephew up at the airport and brought him over. And then Dan helped me do some things around the house that I can't do. And Dan was just fine, happy. We had a good time with him. 24 hours later, he was dead.
Oh,
We haven't seen the death certificate. It maybe was a blood clot, but like I say, he was the youngest, healthiest of us all. So I still don't believe it. I keep thinking he's going to walk through the door. So that's been a real challenge. And then the next day on Thursday, my stomach and my bowels were really messed up. Went to the hospital, had a bowel obstruction, and ended up spending 5 hours on the toilet, either throwing up or having diarrhea. It was not a good day. Then on Sunday, it got bad again, and so I went to the ER, spent 5 hours there. They did a CT scan. I'd only had a X-ray on a couple days before, but they did a CT scan, and there's disagreement whether it actually was a bowel obstruction or gastroenteritis. I haven't really got a definite prognosis on it, but the CT scan did show that from two liver mets, I now got a lot prostate cancer in the liver. And then and I've got a minor pleural effusion, but they're not worried about that at all. And wall thickening in the bladder and the rectal wall. And my PSA is up to like 16, which is by far the highest I've ever seen in my life. But they say all I really can do with that is to keep on the chemo. And yesterday I just had my started my second cycle of the cabazitaxel and carboplatin. And knock on wood, I hate to jinx it, but I think I'm feeling a little better after my first one 3 weeks ago. At least I'm getting a little bit more done and all. But when I came home from, I was like, it was a 6-hour process to drive up to the hospital and to get the chemo and see the doctors and all. And I came home and I was totally exhausted. I just flopped in bed and slept for an hour and a half. And when I woke up, I think I got a taste of what dementia must be like. I didn't know what day it was. I was all confused. When I woke up, I thought it was time to go downstairs and get some coffee for breakfast, and it was 5:30 in the afternoon. It was very confusing. Anyways, today I'm doing better. I've got the pain management with the I keep forgetting the name of the drug, but the one I'm taking it's working. The constipation, I don't have it under control, but I really like not having really any pain. And so I spend a lot of time in the toilet. I take a lot of Miralax and other things, but today I'm back to feeling pretty well. But it's a challenge. So got the hopes up that the second cycle things will get even better.
Yeah.
That's all I got for tonight.
Thank you, Mark. I'm so sorry about your brother. John A., this is something you know a bit about.
Yeah, me too. Sorry about that, Mark. I had a question about that DDL3 business. Was that only if you had done the study, or I thought you said something about you were checking for it.
It's my doctors here or the hospital here locally in Medford kind of screwed up. They were supposed to send samples out because I got the biopsy a month ago, and I just found a week ago they never sent anything out. So Dr. Agrawal at UCSF, he's been sitting waiting for it so he could look at him because he's the one that's leading the trials. But so finally UCSF reached out last week, and I think they just got the samples, but I haven't heard. And he's the one that's one of the leaders of the DLL3 trial, but I haven't heard the results of that.
Okay.
So hopefully I'll learn soon.
And then I had another question. Are all these GI problems, does this have anything to do with your cab-carbo combination or with the carboplatin or something? Or what is this all about?
Nobody said that. So I'm not sure.
Okay.
I just, because like the X-ray they said showed I had a blockage, and it kind of fit. That the day I was really sick, everything I ate that day stayed in my stomach and wouldn't go any further, so I kept throwing it up. Everything else went out as diarrhea, so it's like there was a gate in there. But then in the ER, the doctor who did the CT scan, he doesn't think there is a blockage. He says there's some gas there, and also I'm still not sure.
You got a GI specialist?
We have one, but I don't get to see him till next week. But he's good. I've seen it before, so hopefully I'll learn more next week.
Do you use a palliative care doc too? Or?
Yes, I've got an appointment with him on Thursday. He's the one that's doing my pain management, and but his suggestion for the constipation really it's not working all that well. But I'll put up the constipation if I don't have any pain.
Is the pain medicine what's causing the constipation?
Well, if you look at all the drugs I take, they all cause constipation.
Oh,
So who
geez.
knows? Who knows? I mean, I know that the chemo in the past has caused constipation, but there was an anti-nausea drug I took for a while, and that definitely caused constipation. So I don't take that, and I don't know. I'm getting so overwhelmed by. If I just find some place where I'm comfortable, I'll just stay there for a while. I'm not going to seek out anything else at the moment.
Yeah. Okay. Thank you.
Rick?
Yeah, so I just want to add, I want to wish you much comfort, and may your brother's memory always be a blessing, Mark. I'm just so sorry to hear that. I mean, plus when it comes so suddenly, it's such a shock. That's the problem. I wanted to ask you a couple of things. Are you keeping Rahul constantly in the picture with all these issues that you're going through? I mean, letting him know on the portal, or are you just waiting to speak to him?
I've been waiting. Like he does answer my chart messages, but it's really hard to get in to actually talk to him. And it's just I was waiting to see what would happen today after yesterday's.
Mhm.
So I'm going to get scans. So I'm doing split dose. Yesterday was the first split dose of my second cycle. Next Monday, Tuesday because of Labor Day, I get the second, and then Raul wants scanning after that.
Right.
So,
But what I'm suggesting is don't just use him like he calls the big shots. You got to let him know of all these little things too, because he's treating a lot of people with this combination. So he knows the tricks that your local lady, as good as she is, she may not see it. So when
yeah,
you're sitting in that hospital with bowel obstruction, and then the next day it isn't bowel obstruction, it's gas, or it's this, or it's that, you've got to tell him all these things. Even if he doesn't respond, it's then in your UCSF. And if he sees something, he may say, aha, this is what's going on. This is what they need to know. And he can pick up the phone to you or to your doctor. But a lot of you like to keep your main doctor sort of away because you feel like you're bothering what you're not. I can't emphasize this enough, and maybe the other medical practitioners, well, the medical practitioners, I'm not, but the medical practitioners on the call can speak to this. But it's so important, especially these guys who are calling the shots for you, to let them know how you're responding to these medicines. Same thing with the palliative care doc. Just let him know on that UCSF chart, this wasn't working. You're doing a great job on the pain, but the laxative stuff, that's not working great. And then they can make adjustments.
I hear you, Rick. And he does not respond on weekends. And so this was all like after hours on Friday, and then the ER was Sunday. And then yesterday I had to rush in to get my chemo, and I came home and I was really sick. Today's the first day I've been feeling better, and I should have
No,
contacted him today, but I didn't do
I hear
anything.
you, but when you say he doesn't respond on weekends, somebody reads those messages on weekends. And if they think
Okay,
it's important, they will pass it on to him. So
okay,
we shouldn't be making the calls for what he
okay.
does and he doesn't do. Our job is to make sure it gets into UCSF. We can then criticize UCSF for not responding on a timely basis. But we shouldn't be saying, well, he's not going to respond for the next 2 days, so I'm not going to bother telling him. for 2 days because he will see it. He's got duty nurses and duty people who are reading that stuff all the time, every day, and they make their judgment as to whether he needs to know or he doesn't need to know. So
I hear
this
you,
is
Rick.
not for Mark, for everybody. If you've got issues, tell your doctor. I mean, we've got who have we got with licenses? We got Dr. Paul, Dr. John, Dr. Jack. Do we have any other docs in today? But guys, would you please comment on this for everybody, not just for Mark?
Well, speaking for myself, I fully agree. I think since I was trained, communication between different doctors has diminished quite a bit, and they're leaving it way too much to us to pass the information back and forth when they should be picking. So I completely agree with Rick on that.
Yeah, I'll second what John said. Unfortunately, communication has changed from verbal interaction to messages, and but as has been stated, if you're not your own best advocate, and fervently so, you will be left on the perimeter. So you got to push.
Yes, I agree. And it's very difficult because the patient load for so many doctors out there and centers of excellence in particular is so overwhelming. They tell me all the time because I'm so busy trying to be helpful to them. I feel so sorry for them because they just have so many patients in their schedule, and it's so hard for them to try and, interface with the, radiation oncologists, with the medical oncologists, and all the other palliative care doctors and everybody. And they tell me, it's very difficult. Sometimes I just don't have the time. It's unfortunate. Medicine's changed, and so much paperwork and so much things you have to do besides communicate with fellow doctors like we could in the good old days. So it's sad, but pushing yourself, as Dr. Paul said, and trying to get squeezed in and communication-wise with your doctors is important. And I happen to have a doctor who, for whatever reason, he's terrific and really gets back to me.
Thanks.
Yeah.
Anybody else for Mark? Okay. Frank Chambra?
Yes, so I'm going to give an update of what my situation is also that the Mets have come back on my bones from my sixth treatment of Pluvicto was in April, and I just saw my doc last week, and my PSA was from the Pluvicto was zero point 0.8, and then at 1.8, and now it's 6.85. So right now we're waiting to see if we can get 6 more rounds of Pluvicto approved. That's a possibility for the medical for my insurance. If not, we're trying to see if we can get assistance with that. And if we can't do that, then they're going to throw me in the I shouldn't use the word throw me, but I'm going to enter into a study with the xaluritamig, and it's a study, so I'm not guaranteed I'll get that drug. But if I don't get that drug, I'll get cabitaxel or a second androgen receptor directed therapy. So that's where I'm at. I'm just waiting to see the doctor. We're waiting for the insurances and stuff to come out. But I mean, other than that, I'm still living. I'm still strong. I mean, I do have some pain in my back, but I mean, my spirits are still high and everything's good. That's it, I
Thank you,
think.
Frank. Rick, what's your take?
Well, this is really interesting, Frank, from the standpoint of trying to get another 6 approved, because we have not seen that yet. We have seen people do repeats, but generally it's been because they were in the trial originally, as opposed to it was approved the first time and then it's gone back. They've gone back for a second time. So we'll wait with bated breath. I think you're really on the cutting edge here. I may, well, with your permission, I'll use your name, but I may reach out to my peeps at Novartis just to let them know that we're trying to do this through the James, right? And
Yes, James.
yeah, because I think that they would like to know. I don't know how much they can do, and I will also mention where we want to see if we can get financial assistance. If not, because that would be the doc's first choice. Amir, who's your doc?
Dr. Yang.
Say it again.
Dr. Yang.
Yang. Okay, I was thinking it was Amir, but whatever his last name is, but it's not. It's Yang. Okay. So let us see what we can do. I know the drug you're talking about because I remember seeing a trial on it. Ben, do you recall what it is?
I was
Is that
trying to.
a
509 XALURITAMIG.
Hold on a minute.
I'm
Spell it
sorry.
out again, please. Or
X.
just put it in the chat. Just put it in the chat. Easier than that. Just
Okay.
put it in the
Yes, sir. Okay.
And is this is AMG 509? Isn't it?
Yes.
Ben?
Yes. That's it.
Yeah, AMG. But put it in the chat anyway. This is AMG 509, which we do have some knowledge of. We've had some people. I just have to look, and I'll come back to you when I've just done a little bit of research and see who've seen it. I think it's a what's it called? Help me out here.
Yeah, bispecific.
T cell engager, isn't it? A bispecific T cell engager.
Yes.
And it's but it's not attracted to PSMA. Doesn't it go to something else?
It uses STEAP1.
STEAP1, thank you. Yeah, it's the STEAP1 drug. That's the one. What, Ben? Just give the guys a little background on that drug.
I actually don't. I don't know a lot about it. I've made note that it exists, but I can't give a lot of background this time.
Well, the concept, gents, of the drug, and Ben will correct me. He's better explaining it to you than me because as little as he knows, it's going to be better than what I know. But it is a molecule that pulls in T cells on one side, which are our natural cancer fighters, and it's attracted to the cancer, to a protein on the cancer cell called STEAP1, which they've been messing around with for a long time. Think of it like PSMA. It's different, but think of it like PSMA, that it's a target on the cancer cell. And so you take this drug, there's a missile that is attracted to the cancer cell, and it pulls in a T cell with it in the simplest of forms. I don't know, Dr. Paul or Ben or Len isn't here with us yet, but or Dr. John, anybody else want to comment on that explanation?
Well, that's a good explanation as far as I know. STEAP1 targeted bispecific, yes.
Yeah. And did your doctor explain it to you at all, Frank, or is this sort of helping you?
Oh yeah, it's just a trial. It's in trial right now. That's all I know. And he
Right.
did explain to us about the T cell and everything. So the yeah. So yeah, we're just waiting to see if we're going to go the Pluvicto or go that route. So if we go that route, we might not even get that trial drug. We might just get cabitaxel.
Yeah, you might get the control arm. Well, the control arm ain't so bad, and you may tolerate the cabazitaxel quite well. A lot of people who had trouble with the docetaxel tolerate the cabazitaxel a heck of a lot better.
Yeah.
And it controls the disease. I think from our standpoint, from what we know about AMG 509, is that we'd say to you, yeah, go for it. I mean, we can't give you medical advice, but we can tell you that we've looked at the drug and it seems to make sense. And, God forbid I was in your situation, I would consider it.
Yeah, I
I
want to
bet
go
even,
for it.
yeah,
I
I
want to
bet
go
even Ben
100% for
Nathanson would consider it. Would you consider it, Ben Nathanson?
Um, Steep one gives me pause because, yeah. Um, but yes, sure. If it were offered, if that was the trial at my institution and that's what they offered, I would. And yeah, and I had failed Pluvicto.
Not that
I
I
don't.
would necessarily
Yeah.
know about this, but I don't think there's been a phase 3 trial completed yet on that, right? I mean, the only reason not to consider it is I'm not sure it has actually reached phase 3 yet, but I'm not sure.
right. No, it has not raced. It has not got the phase 3 yet. Actually, this actually says it's the phase 3 study
Oh, okay,
right now.
good.
It just opened up. That's what it is. So they have 600 slots. That's what my doctor said. So yeah, there's a good possibility that I can get in this if the Pluvicto doesn't get approved. That's where I'm going.
Here's something I'd like you to put to Dr. Yang. Maybe one of the guys can do a little bit of research or may know. But we know for sure that there are some alpha trials out there for men who have, where the Pluvicto has failed them. And you may be a really good candidate. Who was it recently that we tried to get into an alpha trial? I can't remember. But we didn't cut. Oh, I know who it was. It was Al Latimer. So Al Latimer tried to get into an alpha trial. And what we should be doing. What was the number of that trial, Ben? Do you remember? I think I have it. And what we'd like to see is if that alpha trial is available anywhere close to you, because you may be a great candidate for that alpha trial. And ask your doc specifically, are there any alpha trials I can try? Or are there any other radionuclide trials I can try? Because if you're a good candidate for that, then you don't have to worry about messing around again with the Pluvicto.
Yeah. I mean, I'm not too happy. I mean, I'm not too fast to want to go back to Pluvicto. I mean, it did its job, but it was rough going through that. But anyway, so yeah, I'm gonna check into the alpha trials for sure.
Let me see what I can find. I'll definitely put a number in the chat window for you, an NCT number, and I'll look at them and I'll come back to you during the meeting if I see
All
anything.
right,
I'm glad I'm not
I'm good.
moderating tonight, Ben.
All right,
So that was
I'm
that
good.
was
Thank you.
that was Alpha Break of the Alpha
Alpha Break.
trials.
Yeah, Alpha Break. That was the name of the trial. Thanks a lot. Yeah. Yeah, I'll put the link in the chat window for you, Frank, on clinicaltrials.gov, and you can look and see where the sites are.
If you still have your email, Rick, it was as you remember, it was in one of the notes I'd written in a previous month. I had a table of the alpha trials with their
Oh,
numbers.
yes. Yes, you did. So
I emailed
look,
it to you. Yeah,
yeah, didn't we put it in, it was in the reminder, wasn't it?
yeah, yeah.
Was that last month or the month before?
Uh, Probably 2 months ago. Yeah, not last month.
Okay, so Frank, go see if you can find the see if you can find Ben's reminder. Oh Jesus. Was that a Tuesday? That was before we switched you, wasn't it?
Yeah.
It was before we switched you. So it would probably be from the month of June. It would probably be the reminder for the 10th of June, I'm guessing. It might be in the reminder for the 10th of June, Frank, if you save the reminders. And I'll try and look later. I can't get to that one right now, or let me know if you find it, because Ben did it. Or Ben, you must have a copy of that as well. You could send it to Frank.
I'm
Yeah.
gonna look right now.
Okay. Okay.
So you good, Frank?
We're on it. We're on it, Frank. We're on it. The forces are coming.
So next up is Jim Kavanaugh.
Yes, thank you. My biggest concerns are I've been having, well, I start out with the good news. The Orgovyx has worked, and I've had my second run. I've ended the 8 months. I was scheduled for a year and a half initially, but it has knocked my socks off. The good news was it's basically down to 0.1, and I had been at 12.3 initially, my PSA. The testosterone is virtually gone, and I have absolutely no energy every day. I have back pain. I've been diagnosed with severe sleep apnea. I'm expecting equipment shortly. I've been in physical therapy under a doctor to kind of strengthen my lower muscles, and unfortunately, they diagnosed me through an MRI and X-ray this week with lumbar spondylosis. I don't have any fractures, but they're saying I should go back to get physical therapy to strengthen my muscles. Instead of gaining weight, which many have on Orgovyx, I've lost weight. I'm down to 124, which is 6 pounds lower than I should be. So I have concerns there. I'm preparing for a discussion with my urologist to find out, can I come off of the Orgovyx, and what are the benefits and risk in terms of that. I also found out this week that I have a bladder wall cyst that may be impairing the urethra. I'm waiting for an MRI to come back tomorrow. But in the meanwhile, I passed a stone, which I don't know whether that was related or not. I have a lot going on.
Yeah.
So can I just say before Ben, because Ben may not be aware, technically what we should have done, we should have treated Jim as a new guy, because he's been in the low intermediate group, although really should have been in this group from much earlier. And I don't think we've ever done an intake on him. He's also been working with Captain Jim for quite some time, and he's a pastor, a former military chaplain, and he gets treated at the VA. If I'm not mistaken, a Marine military chaplain, I think, if my memory serves me right.
I don't get treated at the VA. I basically have been a volunteer chaplain for the Marines, American Legion, Welcome Home Vets, and the National Guard.
Thank you for that.
15 years.
Yeah, so I don't know how you want to handle this, Ben, but this is, I think, really sort of a debut in this group, because we told him we really didn't want to be discussing these issues in the low intermediate.
Okay. Well, Jim, we have a standard set of questions to level set you with the group and then you can ask your questions, although you have already given us quite a bit. So how old are you now, Jim?
I'm 82,
And where do you live?
New Jersey,
Oh, we're in New Jersey.
Morristown.
I'm in Teaneck.
I go to Morristown Memorial Center. I'm actually the face of the Heart Orange program because I have heart history.
How did you? Okay, you heard of AnCan through Captain Jim?
I came in from another cancer group and they had recommended, they saw something coming up and they said they think this might be of interest. And once I came on, I was so impressed by the wealth of knowledge and experience. And, I just didn't know where I fit. But even offline, I didn't want to consume the time of the other gentleman. If you wanted to ask me anything, totally, I give you everything that I can. I also have MS, and Jim Marshall was aware of that.
That's a lot. How old were you when you were diagnosed?
With the MS or the
I'm sorry, back to prostate cancer.
Prostate cancer was last August. They did a digital exam and said, you have prostate cancer. And I started my wonderment, how can you know? And then we went through all the steps very slowly because I had a very conservative urologist. But the more and more we went into it, they found out that we were high on a Decipher score. The cores came back, only 1 out of 10 or 12 was clear. And I think I ended up being a lot of 3s, a lot of 4s, and there were 2 that were 8s. And, it just didn't look so good. And they put me on 5 treatments of instead of 27 or 40. They didn't think that dragging it out would be too great because it tended to be aggressive. And so we went through that. That ended February 28th.
I'm sorry, this is radiation?
Radiation. And I was sleeping 14 to 16 hours a day. I now sleep about 10 hours a day, but I have irregular sleep because of the sleep apnea.
Which you say you're getting a CPAP machine?
It'll be the equivalent of that, but they're adjusting it to a BiPAP. They're saying there's a central thing. They said it's trickier than normal.
Is that related to the MS?
Don't know.
You got an MRI before the biopsy?
Yes.
Have you had any genetic testing?
All I know is what did I call it? I just mentioned the name. It's very high on the scale.
Decipher. Right. That's a little different.
Okay. All I know is the Decipher, and that ended up being very high in the high 90s.
Mine too. I'm still here. So your overall Gleason score, you were a Gleason 8?
Yes.
Was the conclusion. Have you had a PSMA PET scan?
Yes.
And did it find metastasis?
Everything was concerned, but it didn't seem to have metastasized outside of the pocket or whatever they call it.
And not lymph nodes either.
Not what?
It didn't spread to the local lymph nodes near the prostate.
It stayed local to my knowledge.
So did you have a concern or a question in particular that you wanted to ask?
Well, my biggest concern is I can't tolerate the fact that I am sleeping all the time and I have the pain. It's tough to get out of bed every time I use a rocker motion to get out, to get up. Basically sitting on a cushion now, but my pain level's been a consistent 9 throughout the whole session today.
Oh, I'm so sorry to hear that.
No?
Rick, what did you want to say?
So I think there's a number of things, Jim. Are you only on Orgovyx? Did you say you were on Orgovyx? I can't remember. Or did you say you were on Lupron?
Yes, Orgovyx only, and it finishes 8 months in a couple days.
Right. So you're only on Orgovyx, and how long did the doctor tell you you were going to have to stay on Orgovyx?
Initially, he had told me a year and a half, and then recently I told him I'm not too sure that my quality of life can continue at this pace with other
Right.
stuff going on. And he basically said, well, get back to me if you want to go off of it. And now we're at a stage where I want to
Right.
find the pluses and minuses to doing that.
Right. So I think the first thing we got to do is move you to another type of doctor, because
Okay.
the urologist should not be treating you at this point in time.
Okay.
And there are other options, but they're not the sort of options that most urologists are going to think of.
Okay.
So we have to get you to a GU medical oncologist. I would say that your best bet is probably to go see Chuck Ryan, and we can try and get you a quick appointment. He's at MSKCC in where, Ben? He's in the New Jersey. He's in the New Jersey MSKCC, the one on the east side of the state.
Is that what I thought he was in Westchester? No.
No. He's not in Westchester. He's in Jersey for sure.
Well, you can send me those details when you know it.
Okay.
And I'm open to anything. I'm so impressed by
Right.
the knowledge.
So Chuck Ryan is one of the best docs that's out there. I personally known him since 2007, 8. He was the former president of the CEO of Prostate Cancer Foundation, but he didn't get on great with Milken, and so he went back into practice, and he's now living in New Jersey. I knew him in San Francisco. He was at UCSF.
I trust your judgment.
And I think that, rather than going into the city, unless anybody else has an idea in Jersey, I'd like to see you with Chuck. He's caring. He's a good doctor. And I'd like to see if he might consider putting you on a monotherapy second-line anti-androgen like darolutamide. So that allows your testosterone to return, but we block the androgen receptors from taking the testosterone. And that might be a real good alternative. We've got a bunch of guys in this group who have been on monotherapy. Darolutamide, Len just joined us. He's really familiar with monotherapy, darolutamide. And I think it would be a real good alternative to discuss with your doctor, and it may help you feel a lot better. Now, I'm also concerned, as much as they think it's sleep apnea, that what you're going through is these hot flashes at night, which we've talked about before, which can do exactly the same thing to your sleep. And that's a real concern to me. So I'm worried that that laying it on sleep apnea when it might be an issue related to the hormone therapy, and that's another discussion I would recommend you have with a genitourinary medical oncologist like Dr. Ryan.
So I think they test for that. Jim, were you in a sleep lab? Did you wear a monitoring device?
They did it twice at the hospital, Morristown Hospital.
Okay.
And they found out I was very high on it. I think it's scored a 30.
Ah, yeah.
Okay, well then I'm definitely wrong. He is in Middletown. Thank you, Len. Len's put the information on Chuck Ryan in there. What I'm going to do is go one beyond Len, and I'm going to put in the information for you on actually about Dr. Ryan. You can tell him you're an AnCan person. He does know us pretty well.
Thank you.
But that's what I'd like to see. Anybody, and the other thing I want to say is I just read an interesting article that people dealing with cancer who have sarcopenia, which is muscle wasting, one of the reasons may be, and they're doing research into this. I'm trying to think where I think it was UPenn they were doing the research. That the cancer expresses a particular protein that destroys the blood vessels in the muscle. And it's sort of a new idea, and they're doing research. This is not prostate cancer specific, but I mean, there are a bunch of reasons. I'd like to get some input on some of these symptoms from our other two octogenarians who are sitting in the room right now, because I don't think it's going to be foreign to them. So, and they both happen to be doctors as well, so they can give you medical advice, but I cannot. So, which of the two doctors, the two octogenarian doctors, would like to talk to Jim? Who's going to go first?
Well, the sarcopenia issue, this is the first I've heard of it being related to what you just threw out there, but I spoken to my medical oncologist about that, and he said it's definitely related to the low testosterone. And I kept telling him, if I pump enough iron and I really work on it, can I reduce that sarcopenia? He said, not until your testosterone starts to get back to normal. So I've been working hard, and the sarcopenia is not getting any better. And I'm just looking at my arms, and the rest of my muscles just shrivel up. And I don't know what I can really do about it other than wait for my testosterone to come back now that I'm taking a holiday, if it comes back. So I don't know about this new theory with cancer. It sounds interesting, though. I'm going to look at it.
Activin A is the name of the compound. Activin A.
Activin A.
Yes, I'm going to put it in the chat window. Okay? And I'll see if I can find. You just trumped me. I still haven't gotten to Frank's AMG 509, but there's Activin A, and I'll see if I can find out who's doing that research.
So, Jim, I think that's really a terrific suggestion from Rick. Yeah, Ryan is in the top tier. I have never met him, but I've seen him on videos. He seems like a very personable, kind, and also really smart. So the fact that he's in New Jersey for you is fantastic. So, John, what were you going to say, John A?
I was going to ask about your original and present PSA levels.
Yes, it was 12.3. Oh, and when he did the digital exam, I think it was 9.1, and then he said, "Well, wait another 2 weeks and do it again," and then it was 12.3.
And then my second question was that if it's okay with you, since I think it's very potentially important, I would like to take a look at your sleep study. Would you mind emailing it to me?
No problem. You'll put in your chat how to reach you, Dr. John?
Yeah.
And are you're down to undetectable now? Is that correct?
Yes,
Jim?
it's down to 0.1 3 months ago and 0.1 again 2 weeks ago.
Okay, 0.1 or less than 0.1?
Uh, I think it was just 0.1.
Okay.
I don't have it in front of me, but I think it was 0.1. I was so impressed. The fact that 4 people had said they were on Orgovyx and you could expect it to get down to 0. And I thought, no way. And I just blew my mind when I saw it was down that far.
John Maxwell? You cannot, you're not muted, John, but can't hear you.
Select the right microphone, Mr. Maxwell. It's the
How about this?
oh,
Oh,
there you go.
okay.
We
Okay.
got you.
Okay, very good. Very interested in the comment on sarcopenia. I'm on Orgovyx. My testosterone is undetectable, and I'm working out regularly, and I'm not growing muscles, right? So I'm interested in anybody who has background on these further research on sarcopenia and ADT. That's it.
Thanks, John.
Well, I mean, I think one thing, John, is the age differential between you and Jim Kavanaugh.
Okay.
You're 60-ish, aren't you? How old are
65.
you?
65.
65, right?
Yep.
And you know, John and Jim is 82, and that makes a huge difference. So anything that you hear that might be appropriate to somebody in their 80s, you shouldn't read into what you're facing. I mean, I was on for 28 months, 30 months, and I worked out with weights 3 times a week and I built muscle. But I was also 57, 58. So there are other factors too, and we have to sort of factor in everything.
I'm going to hit the gym harder.
Well, as long as you're doing what you're doing, I don't think you can do much more.
Okay. Great feedback. Thank you. Great feedback.
Okay, our next speaker is Barry Blomquist. Barry, you still there?
I'm here.
Up.
Sorry. Multitasking. So I'm following up on my assignment from last week, and I'm still in the process of that, Rick. And John,
You'll have
and
to
so
remind me what the assignment was. Repeat the assignment for everybody, please.
my assignment was to sort out which genetic testing I'm going through
Okay.
or going to get down at Mayo here next month, and also to coordinate with Dr. Heath about the current regimen that they have me on and relay to her what the Minnesota oncology doctor had commented about. And so I'm in process of getting those done. And by next week, I think I'll have made some progress with regard to that, assuming I can get some response. So that's that. But a little bit of update that I did want to relate was that, as you guys probably know, last fall I was at 8 on my PSA, and June 12th it was 435, and June 30th it was 26, and 2 days ago it is 0.8. And so something's happening, and I assume that's good. I'm hoping it's good. And and I'm on day 12, I think, of cycle 2. So starting to feel like a normal human being again. So that's my update.
So Rick, what's his grade on the homework?
Well, it's not as good. I'd have to say it's somewhere between a C and a D, because I'm sure it's in your medical records. You know, if you go into your medical records and just find out what test they did, I strongly suspect, as I said to you, that Hujek did a somatic test for you with somebody like Tempus or Foundation Medicine. And I think you need to look in your records for that. And it came back and it said that you showed RB1. And
that was actually Quan that ordered that test.
okay,
Quan
so
ordered that test, my genetic test, when I was down at Mayo.
and who did he order it from?
Um, I don't know at
Because
the moment, but I can.
but if you
because
if you tell us who he ordered it from, we can figure out whether it was a germline test or a somatic test.
Okay.
And as I explained to you, the germline test is what you inherit, and the somatic test is what your own body makes. And my guess is that he ordered a somatic test. And that now, since you're going back to see the counselor, that may have something to do with they've ordered now a germline test.
The test was collected from Garden 360.
Right. So that was most likely, and we're not fans of Garden 360, which is probably why Quan uses it. But that suggested, if it was Garden 360, we were right. It's RB1 is a mutation that you carry. It's one of 3 or 4 bad guys, like P10 and TP53, and there's another one that I've been trying to remember today, Ben. What's the other one? There's another one that goes with those that trick bandits.
Right,
TP10,
P10,
TP53,
TP53, RB1, and anybody got another one for me, or I'm going to have to do my research again. I can't remember. Anyway, now
EGFR amplification.
No, that's
Okay. Because
different.
I did have a TP53, and that was 12.8%.
And do you have RB? And you have RB1 as well, correct?
RB1 loss, single copy deletion detected. No percentage.
Okay. So single copy deletion, is that's enough to give you the mutation, correct, Ben? I get confused. This is getting more than I know, but not more than Professor Ben knows.
Not so fast. I think that's the first shot of a 2-shot.
Yeah. So with you carrying TP53 and P10, and sorry, RB1, probably means in the long run you're not a good candidate for Pluvicto. it definitely is a good reason to have added the platinum drug, which is why they did it.
They haven't done it yet. They're talking about doing that after
But
I
they're
do a scan in
talking
September.
about it. But that's definitely a good reason to do it, and definitely discuss that with Heath. Oh shit! Can you guys still hear me?
Yeah, this happened to everybody.
Yeah, we
Okay.
can hear you
Yeah.
though.
Yeah, and here's what Dr. Heath is doing, and it's so smart. I love it. She's now having you do a germline test because she wants to know, did you inherit those or did you make them yourself? And it's not necessarily something, it didn't occur to Hujek. Otherwise, he would have just given you a germline test. Because when you get these tests, we can't tell from Guardant how that mutation came about. So we have to do a second. And because if it's inherited, it can have implications, not just for any of your relatives, brothers, sisters, children, etc., etc., but it can also have a significant implication for other cancers for you. And so what she's trying to establish is, are these somatic, which we hope they are, or is this something that you inherited? Because then, for example, the TP53 is called Li-Fraumeni syndrome. You can look it up, Li-Fraumeni, Li-Fraumeni. And it has a lot of other implications. RB1 can have implications, although as Len and I figured out, we don't think that has a name like some of the other ones. But that's what's going on, Barry. And that's
Okay.
why she's having you do a germline. Now, a lot of times we have people do germline first through promise, but that didn't happen with you the way it came about. I mean, it's sad to me that when Quan saw that you had TP53 and RB1, he didn't say, you know what, we ought to do a germline too. Shouldn't have taken, in my view, shouldn't have taken Dr. Heath to say we need to do that. Quan should have known better. He should have been looking out for you and your family and said, yeah, we've got to do a germline here because this could be an inherited mutation.
Okay. I'm teed up for those the 26th, I think, of September.
We good, Rick? Yeah, I think the inherited disorder you get from RB1 loss is the reason it's called RB is retinoblastoma. Blastoma is a kind of disease that kids usually get, and it's in the retina. So Alan, you're next. Oh, no, I'm sorry, you've already gone.
Thank you.
We moved you to the front. Jay Mills, you're next.
I have to give some background. About 5 or 6 years ago, I had gone through a radiation, high dose radiation, followed by IMRT, and a spot to the rib that had been picked up on a PSMA scan, and did 20 or 22 months of Degarelix, and about 6 months, 4 to 6 months of abiraterone and prednisone, and had been undetectable until about a year ago, and started rising. And my numbers over the past have been in July 18 of 2024, 0.1, August 28th, I started shifted to a month later to sensitive, ultra sensitive, and got 0.096. 5 months later, January 22nd of 25, 0.201. Then in May 20th of 2025, 0.305. Then August 20th, just the other day, 2025, I was at 0.463. So it looks like the doubling time is about 6 months. I had a PSMA when it went to 0.2 back in January, and I had a PSMA scan and it was clear. And I'm scheduled for one in about a week's time, another PSMA scan. And that's where I stand right now. And anticipate that I will be going, something will show up and that we will, or there'll be time to jump on treatment. And so I'm anticipating that.
Did you have a question?
That Rick had recommended when last time I participated back in, I believe it was
January, I think.
January, yeah, and it was that we were talking about who would I look to as my GU med onc, and I had mentioned the fellow I had worked with before, who is now in Minnesota, was at Johns Hopkins, and Rick was saying that a med onc at MD Anderson might be a good candidate for me. I'm willing and able to travel, and trying to remember her name.
Yeah, it wasn't MD Anderson, it was Houston Methodist. She was formerly at MD Anderson, but for reasons that I can't really talk about right now, I would just put that one in the hopper for the time.
Okay.
Not that there's anything wrong, or she's great, but there's some things happening, so I don't want to send you down there with. So I would say Antanarakis is a great option. If you want somebody closer, Shmulowitz is a great option in Chicago. Those are a couple of thoughts, Jay.
Okay.
You can't go wrong with Antanarakis. Honestly, he's really, really, really good. So.
Okay. Well, anyway, that's I'll perhaps have some more discussions with folks about that idea. I really don't have another question other than at what point should I expect for something to show up on a scan, or to say I need to do something before then?
That's a great question. Anyone have thoughts on that?
Well, I can tell you, Jay, that we have one fella in our group whose PSA went up into the 20s, and we still didn't see anything on PSMA PET scan. And he also had FDG and a few other types of scans, and nothing was showing up. So it's difficult to say, oh yeah, you'll definitely pick it up at 0.4 or 0.6. So you know, anybody's guess is good.
Okay.
You know, I'm just thinking, Jay, maybe it wouldn't be so bad to reach out, because the doctor who I recommended, who I'm thinking of, will also still see patients in Houston. So you may not have to schlep. And it was Dr. Eleni Evstathio. She's on our board. If you look her up on our board, but that's also a possibility. And the fact that they both happen to be Greek means that you'll get a good moussaka with whichever one you see, and a glass of Retsina, and they know each other quite well.
Right.
But it's really your preference. I mean, she is outstanding. She is. There are changes afoot. Again, I can't say more than that. But
I don't know how much time I have, but so I need to start. I just need to start listening more to the everybody's saying about their docs and how well they're received in the field. I will definitely. Now,
here's the difference: they're both exceptionally smart, and they're both good, kind people. But Dr. Evstathiou is a lot more gregarious. Do you see Joel Blanchette in this? Do you know Joel? Do you see?
I know the
Well,
name.
you see, well, on my screen, he's two above you, but he won't be two above you where you are. Joel, wave your hands around and do something so we can see. You see somebody waving. Yeah. You see that? You see that lovely lady behind shoulder? Yeah. That's Dr. E. That's Dr. Evstathiou.
Okay.
So
must be.
You know, so you get the picture. You know that they're very different person. She's a big personality, and Dr. Antonarakis is great, but he's not a personality like that. Depends what you want, you know. But they're both very, very smart and really good docs, and they care.
Very good. Thank you. Yeah.
You know what, Joel? That picture speaks a picture's worth 1,000 words. Isn't that right, Jay, in this case?
Very, very true.
I've had the great honor of having both Antonarakis and Dr. Evstathiou as doctors, as GU medical oncologists treating me. So I've been very privileged, and largely because of Rick.
And what would you say about the choice between the two, General?
They're both very smart, and they're good researchers, and they're good at getting you the latest in medicine. Dr. Evstathiou is a little more avant-garde, and she is probably a step ahead of Antonarakis as far as research and trying new things and applying. She believes in personalized medicine, and that's why she moved away from MD Anderson, because they didn't allow her to do that there. So, so that's basically what I understand of her.
That speaks volumes. That's a good endorsement. Thank you.
Yeah. You know, what is it they say in the MasterCard ad? Jay, you can't buy this, right? What is it they say in that Master? Yeah, you can't go out and buy this information.
Right. That's right. Okay. I don't really have any other questions about, unless someone has anything to volunteer. I'm sort of in this no man's land at the beginning of re-entering the process. So, thank you all.
Thank you, Jay.
For Jim Kavanaugh, I just put Dr. Ryan's actual link in the. Well, I sent it to Jim Marshall. I'll put it in again, but I'm just putting that in, and I haven't forgotten you, Frank. I'm working on AMG 509. I just keep getting sidetracked here. Sorry.
Thank you, Rick. I have the information on you. I need Dr. John's information to send him the sleep study.
Oh yes, he sent it just to me by mistake. I'll put it in. I'll put it in for you.
Thank you very much. Everyone is in my prayers, by the way.
Thank you. Especially, please keep Mark Valens especially in your prayers, if you would, please. Okay, there you go. Right underneath Chuck Ryan's URL is Dr. John's email address.
Thank you.
So that, as far as I know, that is everybody who wanted to speak. So we
My
haven't
God.
saved, even with lots of long side talks, digressions. So
Oh gosh.
we can splice in Jamaican as we promised.
Yeah.
Yes, let's get Jim Aiken in and give him some feedback on what to expect. Go ahead.
I've done my research. I know all the side effects. I've been researching each side effect, how to do, what not to do. I guess I need to know what to expect once I start the drug and when do these side effects start kicking in. If they,
We're all kind of,
assuming they do. Now, I've got a friend here in Nashville who's been on Orgovyx for 18 months and no side effects at all. Weird. I don't understand. So,
well, anybody want to respond? Quite a few first-hand accounts in this call. General
I,
Joel,
I
what do you say?
I would just say before Joel starts, you probably hit the nail on the head, which is that every man is different. So whatever anybody tells you right now, don't expect that it's going to be true for you because every man is different. But please go ahead, General.
That's a great point, Rick. That's
Uh,
yes, Joel, please go ahead.
Dr.
Sorry.
E had me on Orgovyx for 24 months. Then I had a holiday of about 4 months, and then she put me right back on because I have the TP53 gene and the P10 gene also, which are aggressive cancer genes. She's watching those genes very carefully with the Tempest test, which she administers to me every 3 months. And I just heard from her yesterday or the day before in my chart, and she says I'm still at 1%, whatever that means, on the Tempest test. So she just wants to keep on uh, keeping me on the Orgovyx and the darolutamide for the foreseeable future and testing me every 3 months. That's her plan of attack on my cancer.
John Maxwell, what do you say?
I thank you very much. I have been on Orgovyx and abiraterone for 6 months. I had absolutely no side effects for the first 60 days. Now I'm getting hot flashes, although my my trusty Ember Wave is helping me reduce those, which is very nice. Ember Wave 2, and I get a little bit of neuropathy, not a lot, but just a tiny bit of neuropathy, maybe a little fatigue, and obviously the muscle wasting. But I'm working out and I'm holding my ground. Let's put it that way. But those are the side effects I've got. In the big picture, I don't feel too bad about that.
okay. Thank you.
So who wants to give Jim some sort of basic guidelines? And loads of you are on here. You all know this on what to expect once he starts on the Orgovyx. Now, I will say Orgovyx doesn't start quite like the uh, the. I'm having a senior moment. Um, it doesn't start like Lupron and Eligard and those other drugs. It cuts off your testosterone right away. It's an antagonist. That's what I was looking for. It's an antagonist and not an agonist. But who's got some thoughts on how he should handle what he can expect and how he could handle it? And everybody in this group has experience in that.
Bill, you?
Uh, so Jim, I've been on Orgovyx about 11 months now, and as has been said, it's going to be different, I'm sure, for you. But here's my take. Um, right away, probably within a week, um, total erectile dysfunction, um, loss of libido. Um, you notice, you know, loss of blood flow to your genitals. You might see some shrinkage. I started low dose Cialis just a couple weeks after Orgovyx, so 5 milligrams daily. And that helped a lot as far as just keeping the blood flowing and helping to prevent atrophy. The other big things for me that have been um, somewhat of a bit of a challenge. Probably the biggest one is fatigue. I'm just, every afternoon, almost without fail, I need to take a nap. And I'm lucky I'm in a position where, you know, that's easy for me to do without impact. Uh, Brain fog is kind of a frustrating one. I have a lot of those moments like Rick was just having where you're searching for a word. Um, and I used to really pride myself. I had a great memory for detail. Um, I can usually remember, kind of like a dementia patient, as I've learned, the old memories, but it's more the short term kind of thing for me. Um, but I think you may experience some of that. Hot flashes, yeah, I get them, but for me, they're quite mild. So I'm very lucky there. And of course, yeah, the muscle wasting, it's not fun. Um, I've been pretty active through my life and played a lot of sports. And after several months on Orgovyx, even after going to the gym and stuff, I tried to do some push-ups. I could do like 3 push-ups. I mean, it was humiliating to myself. Um, but keep, you know, doing some kind of weightlifting, resistance training, that's going to help. Um, just stay active as much as you can if you're able. I think that's about it for me. That's my take.
Thank you. Very
You're
good.
welcome.
Marc V.
Yeah, one of the things I had to learn when I was on Lupron was that before, if I would have a low energy day, it meant that I didn't have enough food. So I had to eat something, a slice of bread with peanut butter and jam on it, and I'd be back at it. Once I didn't have testosterone, that didn't work. I felt like crap. So I think, oh, I'll just eat something. I still felt like crap, but I started to put on weight. Food didn't help with feeling like crap. And so it wasn't a solution. And so that was just to cut back my weight gain, I had to cut back what I ate. And that was a learning thing I had to go through. That's all.
Are you demoralized yet, Jim?
Good. Thank you. Yeah, that's good advice.
Dr. John?
Jim, I'm a little puzzled because I know you had a long period on active surveillance, very stable, but didn't you have your biochemical recurrence like 5 years ago or something? Is this the first time you've ever been on ADT?
Yes. I had proton radiation in 2009, and
But you
went for
had
12.
your PSA popped up way back in 2019, right?
No, 20. No, my PSA started going back up in 2023.
Okay, okay.
So I went 12 years with it being below 0.6, 0.7. Then in 2023, it went to 1.5, and then and considering going up to currently is 4.7.
So from 2023 all the way to 2025, you weren't on any treatment, even though your PSA was kind of creeping up gradually. Oh, I understand. Okay. Thank you. It's always been a little puzzle to me because you have this very benign biopsy and yet you're metastatic. So I don't know. I guess what we go by is the PET scan, not the biopsy.
All right.
Right. Okay. Thank you.
Rick?
I just thought of something when John McPhee was speaking that I meant to tell Mark Valens earlier on, to make him feel a little bit better. This state where you wake up and you can't remember things has happened to me more than once. It's a very weird feeling. You can't remember what day it is. You can't remember what month you're in. You can't remember the date. It's like so weird. And you're like searching around and you think, oh my God, my memory's gone crazy. What is going on? What is going on? And it's probably happened to me 5 or 6 times in my life. And one of the first times it happened, I was in Bucharest, and I came out of the gym, and I couldn't even remember where I lived, and I just sort of followed my nose, and I got myself back to my apartment, and it was really weird. The last time it happened, I spoke to the doctor, or maybe it was the time before, and what they said to me is that it's a very often it's due to lack of hydration and or food. That if you haven't had enough food or you haven't drunk enough, that you can have this on a temporary basis. And so I've been more careful, especially, and I'd been in the gym that first time, and I'd been working out quite hard. And so I just want to say that it may be nutrition related when you get into that weird space where you can't, like, can I remember my name? I mean, you're asking yourself, can I remember my name? Who am I? And yes, it may well have to do with a lack of nutrition and hydration, Mark. So just keep that in mind, and it's not as scary as it seems. I've found out, because it is a very weird feeling, and it is very quite scary when it happens, and that might help you too, John. Just saying.
Sure, I've had several of those episodes during this call. Am I supposed to be moderating?
Called senior moment.
So, okay, so this is about our time. Thank you all for joining. Any parting thoughts, Rick?
I'm just about to put a link to that AMG, the xaluritamig. Finally got to it. There's the link. And Frank, I'm going to reply to you as well on your other question. Before we hang up, but no, I just can't believe that we got done right on. We got done right on time. How about that? That's because Ben's in charge. Never happens when any of the rest of us, right, Len? Does it ever happen when you're in charge?
Once in a while.
Good night, everybody.
All right. Goodbye.
Thank you, everyone. Good night.
Hold on, Frank. Don't go away.